I will share my screen. Can you see the screen?
Yes, sir.
Okay, let's start. Right, so this practical is on ENG or electroneurogram, where we record action potentials from after stimulating a nerve. So that is why we call it ENG. Sometimes it goes as ENG, EMG, electromyogram. Same machine is used, but here or sometimes it is known as some people call it AP or EP studies, electrophysiological studies. So it's basically meaning the same thing, but here ENG is the common one in Sri Lanka. So you need to know ENG means electroneurogram. So the objectives of the department, practical objectives are shown here. So, so before we go to the recording, you must know some theory aspect. So you must be able to draw and label an action potential of a nerve fiber. Same is true for a skeletal muscle fiber, more or less same. So that is one thing. And then you must know what is a compound action potential. Draw a compound action potential. And then in the ENG practical, you are expected to know certain terms known as distal latency, proximal latency, and then it's a time actually. I will tell what it is. The difference between the two values, that is called latency difference. So the proximal latency is does somebody have any question? Okay, latency, proximal latency is little bigger than the distal latency. So when you calculate the difference between the two, it is called latency difference. And then you must know what is the amplitude, that is the height of the action potential recorded. And then fourth objective is calculating the nerve conduction velocity using the above three parameters, 3.1, 3.2, and 3.3 can be used along with some other thing, actually latency difference along with distance can be used to calculate the nerve conduction velocity. I will discuss it during this 1 hour. And then state the clinical significance of the parameters stated above in axonal loss and demyelinating diseases. So if you take nerves, they undergo certain diseases, just like any other system. Nervous system also undergo disease conditions. Sometimes the peripheral nerves undergo disease conditions. Nerve can have demyelinating diseases. Myelin sheets can be lost. So, as you know, myelin is important for nerve conduction. Rapid or fast conduction is due to myelin. Saltatory conduction, myelin sheet helps. So if there is a demyelination, nerve conduction velocity will go down. If the axons are lost, so if you take a say ulnar nerve or median nerve or whatever peripheral nerve, it has thousands of nerve fibers, and assume that it has 1,000 nerve fibers. When you stimulate that, it will produce action potential in your muscles, or muscles will be stimulated. if there is an axonal loss or neuronal loss, and the nerve contains not 1,000 nerves now, 500 nerves, what will happen? The stimulation that goes to the muscle will be 50% reduced. So the action potential, the compound action potential developed in the muscle will be shorter or smaller, right? So that is also I will explain later using diagrams. So those are the two objectives. And let us go to the next slide. Right, just to refresh your memory on action potential of a single nerve fiber. This is using two electrodes. One electrode is placed intracellularly inside the nerve. The other one is kept outside, just inside the membrane and outside the membrane of the nerve. And if you stimulate the nerve fiber while recording the activity of these two electrodes placed inside and outside, you will get something like this. Just before recording, before stimulating, you get the value called -70. That is the resting membrane potential. Right? Resting membrane potential, that is stage 5. And then at point 1, you give a stimulus from outside. If it is a very small electrical stimulation or very small chemical stimulus, it may generate some action potential which may die off, right? And get a pointer. So you see, you develop an action potential which will die off. Few sodium channels will open and nothing happens, it will die off. If you give a little bigger stimulus, it will open a little bit more sodium channels, that will also die off. But if you give even bigger stimulus, it will reach what is called the firing level or the threshold, and that will not die off. After reaching the threshold, what happens is it will undergo what is called all or none phenomenon. That means it will, all the sodium channel voltage get sodium channels available will open up, and very rapid entry of sodium will occur, leading to the depolarization. So it is polarized. Inside is minus, outside is plus, or negative and positive. So therefore we call it polarized. When it goes towards 0, we call it polarity is lost, depolarized, plus overshoot. It goes even above that, about plus 35 or so, it will go, and then sodium channels will close, and the membrane begins to come back towards the polarized state. We call it repolarization due to opening of potassium channels. So this is due to sodium channels. This is due to opening of potassium channels, moving of efflux of potassium. This is influx of sodium, efflux of potassium, and then it will not stop immediately at -70. It will go a little bit below, not this much. This diagram is a little too exaggerated. This is called hyperpolarized. It becomes even more polarized, and then resting membrane potential is re-established, right? So this is the recording from a single nerve fiber using intracellular electrode. So this is not what we are recording in this practical. What we show is recording using surface electrode, right? And you can record actually muscle activity using needle electrodes also. You can puncture a muscle and record also, but we are not doing it in our department. We are using surface electrode to record. So again, this previous slide showed, this one is showing what are the ionic changes that occur. The yellow one is sodium channel opening, and green one is actually, so the first one is until the threshold is reached. Once the threshold is reached, more sodium channels open, the green one, and then sodium channels close and potassium channels open. It's the bluish one, the last one, and the resting membrane potential is re-established, right? And then if you record on a nerve, you get in the concentrate on the top panel, upper part, panel A. You have a nerve here. You have a stimulating electrode, positive and negative ends. You stimulate here, and then the distance away, D is the distance away, you place a recording electrode and record the traveling action potential. As you know, a mixed nerve in the peripheral nerve will have different types of nerve fibers. A fibers, B fibers, and C fibers. And as you know, A fibers are fast conducting myelinated fibers. That is also subdivided into A alpha, A beta, and A delta fibers. Depending on the degree of myelination, they are classified, and they conduct at a faster rate. When A fibers conduct at a fastest rate, A alpha, C fibers conduct at the slowest rate, and also their stimulation thresholds also may be different, right? And so when you stimulate, now concentrate on the panel B. There are 1, 2, 3, 4 lines. Pay attention here. You give stimulus here at this point and record using the second panel, the on a computer with appropriate software. You can record it. When you record, you give a stimulus. If the stimulus is very small, and because in the y-axis it shows increasing stimulus current, you can give say few millivolts, say 2 millivolts to begin with. For example, 2 millivolts, it just stimulates some fast conducting fibers, A alpha fibers, only a few, nothing else is seen. And then you increase the voltage. Even in our ENG machine in the department, you can rotate something and give the stimulating current with a incremental stepwise increase. So initially 2, then you can go to 4 or 3 or 4, and so assume now you give 4 millivolts. What happens? A alpha fibers stimulate, but the height is little bigger because more A alpha fibers got stimulated, and at the same time A beta fibers also get stimulated. And third step, you stimulate even bigger, say 6 millivolts. What happens? A alpha, all the A alpha, most of the A alpha fibers are stimulated. A beta fibers also stimulated, and some other fibers also start getting stimulated. And then you stimulate even higher, say assume 10 millivolts. A alpha reaches maximum height. B also very tall now. A delta and other A gamma, A delta, and B fibers also stimulated, and C fibers also give a little hum, but they are slow conducting, takes a little longer to appear. C fibers maximum conduction velocity is 2 meters per second, whereas A alpha can reach 100 meters per second, like sciatic nerve or proprioception carries in A alpha fibers, very fast conducting. C fibers are like sympathetic nervous system. Sometimes they do have unmyelinated fibers, right? So they are little slow to conduct, and so you can see different types of recordings on the nerve itself. And same thing is shown if there's a muscle here. Muscle also produces compound action potential because muscle also has many muscle fibers. When you stimulate, give a very small stimulus, only few nerve fibers will stimulate, and that will stimulate the corresponding muscle fibers, only a few. And you increase the stimulus, more nerve fibers will get stimulated, more muscle fibers will get stimulated, and they reach the muscle at different times depending on the conduction velocity. So the muscle also produces compound action potential. That is actually what we record in the same kind of thing in the ENG or EMG, electroneurogram, electromyogram. What we record here, you stimulate say your median nerve or ulnar nerve here, you record in the hand by keeping on the surface of muscles. You keep surface electrode attached and keep the recording. And what you want is what is called supramaximal stimulus. So you keep on increasing the stimulus until you reach the peak values. Say, assume now you reach this figure, this type of impulse when you stimulate using 10 millivolts. Before that, 8 millivolts, it may look slightly smaller, different, 6 millivolts smaller. So at 6, you increase it to 8, you see it getting bigger. You go to 10, it gets little more bigger. And then you go to 12. And at 12 also, if you see this one, that is a supramaximal stimulus, well above the threshold for all the nerve fibers. So that is what we get. We do not go sub-threshold stimuli, we use supra-threshold, above threshold stimulus to record, right? And we get something like this. So stimulation, you give only few millivolts, but the patient will, you have to warn the patient, okay, I'm going to give you a small current through your skin and stimulate. You may feel it and he will jump, right? So just like you get startled, and unless you warn the patient, he will, like hold off the chair, right? You can do it while patient seated or lying down position, doesn't matter, but you must warn the patient. You will give a small current to your hand, and you may feel it, may be little uncomfortable sometimes, give a little discomfort, don't worry, and the muscle will twitch, and the hand will, just like due to current, muscle contraction will be felt and seen, right? So so this is the same kind of thing recorded beyond this point. So this is, in this diagram, this is kept on the nerve itself, but further down in the muscle, on the muscle you can keep, you will get similar behavior, right? So that is the basis of electroneurogram. You give a current to a nerve and you record on the corresponding muscle supplied by the nerve using surface electrodes, right? And using needle electrodes also you can record muscle activity, the action potentials and things, but it is not, it is beyond the scope of this practical. We are talking only concentrating on this one, and this type of action potential is slightly different to what we saw previously. So we saw this is single cell action intracellular recording. This one is multi-cell, at the same time stimulation of several nerve fibers give rise to this type of action potential. This is what is called compound action potential. It's the action potential generated due to various types of nerves conducting at different speeds with different diameters, A alpha, beta, B fibers, C fibers, all of them getting stimulated at the same time with slight temporal gaps, time gaps, right? And you see the compound action potential. And here is one example of what we do. We commonly, a lot of patients come into our department, physiology department, to get tested for what is called carpal tunnel syndrome. I hope you know what is carpal tunnel. In anatomy, you must have learned that is in the wrist. The median nerve goes through the carpal tunnel, and there the nerve gets compressed. And when the nerve gets compressed, patient feels numbness in the palms, and it can extend upwards also, and also cause pain in the forearm region. Patient is feeling pain, and particularly gets worsened by movements, like when they hold something, say handling the motorcycle handle, or when sweeping, or when squeezing milk for coconut milk, and sometimes even during sleep, when they sleep also they feel it because of the compression of the nerve at the wrist. So then we have to study the median nerve conduction patterns, right? So what we do, we will talk more about carpal tunnel towards then, carpal tunnel syndrome. what we do is so that is why in second MBBS level you must learn your anatomy well and also physiology, because if you are doing this, you must know where the median nerve is going. Physically, surface marking, you should be able to guess, okay, underline this area under the skin, median nerve must be there, and you place your stimulating electrodes in the antecubital fossa or in the elbow region, uh, where you think the median nerve is, and you stimulate. And if the patient is thin person, it is easy to stimulate. If the patient is a fat, obese person with a very high subcutaneous fat layer, you have to increase the voltage. More current has to be given to stimulate the nerve, which is underlying nerve. And so that you stimulate from here, and the impulse will travel along here and reach the thenar muscle here, and you keep the recording electrode, two recording electrodes connected to a machine, ENG machine, and you get a reading on the machine. And it takes, so when you stimulate, you see some artifact in the recording body. Just some, we call it artifact, and we know that is where stimulation started. Probably that is because the traveling of electrical traveling through the skin quicker traveling, and the nerve this will pick it, so you can see a little disturbance in the recording thing. That is the beginning initial point, and then it will come along the nerve, and then neurotransmitter acetylcholine is released, and it will go and bind to the muscle, and muscle will, sodium channels will get activated, and the muscle will get depolarized, and then electromechanical coupling and the calcium amount in the cytosol or the cell inside the muscle cell increases, actin mass interaction occurs, and the muscle contraction occurs, and that will generate that action potential that occurs in the muscle will generate some signal that is being captured here few milliseconds after the original stimulus, because it has to travel, and then it has to go through the neuromuscular junction and stimulate the muscle, and that is quick and it takes time. So that gap is known as latency period. Right? So, and we can stimulate the same median nerve here as well as we can stimulate at the wrist. Just at the wrist here, you keep the recording electrodes here. You can stimulate it from here or from the elbow, right? So when you stimulate from here, it will take smaller time. It will quickly go and stimulate the muscle. When you stimulate from here, it will have to travel from here to this place, and then it will take the original time. When you stimulate from the wrist, assume that it takes 3 milliseconds to develop the action potential, beginning of the action potential. So the latency is 3 milliseconds when you stimulate at the wrist. When you stimulate at the elbow, it takes little longer, because it has to travel from elbow to the wrist, and then same 3 milliseconds will take. So 3 milliseconds plus this time taken to travel this distance. So maybe 5 milliseconds or 6 milliseconds or 7 milliseconds, depending on the conduction velocity, right? So that is the basis of now conduction velocity is calculated using that knowledge. You apply that knowledge to calculate the nerve conduction velocity. So stimulating here will give rise to an action potential with a shorter latency period, and we call this distal latency, because this is the distal side, this is the proximal side. So the distal latency is one you get when you stimulate from this place, and distal latency is generally about 3 milliseconds or 4 milliseconds, 2.5 milliseconds, very small number. And from here it may be 3 more milliseconds added up, because it has to travel from here to here. Then it will take the usual time from here to here, same time, right? So keep that in memory, and we will go a few more diagrams I will show, which will show basically the more or less the same thing. Say again, this will show, give a little bit more detail. So this is the recording electrode. This is the stimulating electrode, that site 1, wrist joint. This is the elbow side, median nerve is stimulated at the elbow. You can see when you stimulate at S1, that is wrist, this exists the initial artifact, small disturbance seen here, and then it takes a little gap and compound action potential starts. So you can look at the shape of the compound action potential, and it's different to the spike potential. Spike potential is very sharp and coming down. That is the, if you record using intracellular electrode, that's very sharp rise and come down within 2 to 4 milliseconds it is over. But this takes a little longer, little spread out thing, and this is the compound action potential. So to the place where it begins, if you calculate the time gap from the artifact, that is the stimulating point, to the beginning of the action potential, that is called latency. And this site is the distal site, and therefore we call this gap from here to here is called distal latency, or DL in short. Whereas here, so it's the same. So original one is about this much, but now this one has additional length here. So this total length is bigger than this gap, this latency, and this latency is known as proximal latency, because there is a more proximal side. Elbow is more proximal to wrist. So this is proximal latency is longer than the distal latency. Is it clear up to now? Can you hear me? I know that. Sadappa danayana kawudu?
Yes, sir, we can hear you.
Innone manga illada gelu. Right. Okay. So this is actually what we are recording is motor activity. So therefore we call this the motor studies, not sensory. We can do the sensory studies, which I am not going to talk. Say if you put a stimulating electrode in the ring finger, there are ring electrodes. Then you record from the nerve. On the nerve, you keep the recording electrodes, and you stimulate the skin over the finger. And you can study the do sensory studies. That is also sometimes needed, but we will concentrate to understand the principle only the motor studies, right? So it's stimulating a motor nerve, the median nerve, and we study the motor aspect, not the sensory aspect, right? And okay, so this is the distribution of the nerve or the nerve supply. The ulnar nerve supplies the little finger and half of the ring finger, and these 3 fingers and half, 3.5 fingers on the outer border, the radial border, is supplied by the median nerve, right? And there are communicating branches and some aberrant connections in some people, so don't worry about it. Usually we know that thenar side is supplied by the median nerve, hypothenar side is supplied by the ulnar nerve. And you can record the motor activity of the median nerve by keeping recording electrodes on the thenar side and stimulate the median nerve stimulation here. Or you can study the ulnar nerve by keeping electrodes on the hypothenar side, hypothenar eminence, and then stimulate the ulnar nerve, right? Ulnar nerve also can be stimulated at the wrist, or just at the elbow also you can stimulate. And generally when we study for carpal tunnel syndrome, we record both nerves and compare actually, right? So you can even stimulate at more proximal site, like in the shoulder region also, in the axilla or in the cervical region, you can stimulate, and it takes even longer time, bigger latency, right? Depending on the length, it will take more and more time, right? So this is the distal latency, this is proximal latency at elbow, this is proximal latency at clavicle or the axilla, right? Above. And this is actually ulnar nerve. No, it's hypothalamus side. It's stimulating, right? And one more thing that you need to pay attention to is wherever you stimulate, it is the same nerve. Final outcome is the stimulation of the same muscle, and therefore, if you give a supramaximal stimulus at this side as well as at this side, or even above at the axilla, the final waveform should be similar. If you get a different wave shape here, you are not stimulating the same nerve, right? You may be stimulating some other nerve and some cross connections are getting recorded. So that is not what we want. We have to stimulate the same nerve at two different points, and then only we can do the conduction, nerve conduction study, right? So, our action potential should look, compound action potential should look the same. Here you can, it is evident, no, it's the same, more or less same pattern. But the height and the shape should be very close to each other. Right now, here some numbers are being given. So this is stimulating at which place? Wrist. At the wrist, it is distal latency 5 milliseconds in this example. Proximal latency, median nerve 7.4 milliseconds when stimulating at the antecubital fossa, that is elbow. And ulnar nerve also shows the same pattern. Proximal distal latency is shorter. Here the distal latency is shorter. Proximal latency is longer. Here also ulnar nerve also shows proximal latency is longer. And then we have given some numbers. I will tell what we do in the next slide. I have taken some example. Okay. Calculation of motor conduction velocity, MCV of the median nerve, right? Motor conduction velocity of the median nerve. How do we calculate the velocity? If you want to calculate the velocity of a car or person walking, what are the things we need? Velocity. It's distance divided by time, no? So latency is a time. Say this latency is time. How much did it take? So here, distance between two stimulating points has to be measured. So if you stimulate at the wrist, and if you stimulate at the elbow next time, you can mark it. It's a small pen. You can draw a small line. Here also you draw a small line. At the end of the recording, you get a meter ruler or some tape or something and measure the distance from between the two sides. How many millimeters? Say generally it's about 220 to 130 millimeters. That is 20 centimeters or so is the distance between this point to this point. And that is the additional time taken. So original one, when you stimulate from wrist, it takes 3 milliseconds. So in this example, I have taken it as 3.2 milliseconds. Distal latency is taken as 3.2 milliseconds. So when you stimulate here, in 3.2 milliseconds, action potential comes. Compound action potential comes. When you stimulate from here, in this example, I have taken it as 7.2 milliseconds. It has to go from here to here, and then 3.2 milliseconds will be taken. So this additional 4 milliseconds is taken for impulse to travel from here to here. And that distance, if we know, we can calculate the nerve conduction velocity. So distance is 220 millimeters when we measured using a ruler or some measuring device. and then you get latency difference, proximal latency latencycy we minus distal latency. And these are spot questions. This equation can be given for a spot. Right? So we can give the numbers and we can ask you to calculate the nerve conduction velocity. And so if the distance is 220 millimeters, proximal latency is 7.2 milliseconds, distal latency is 3.2 milliseconds, 4 milliseconds is the latency difference, which is the time taken for impulse to travel from wrist, elbow to wrist. And gap between elbow to wrist, two stimulating point, gap between the two stimulating point is 220 millimeters. When you calculate this, 220 millimeters divided by 4 milliseconds, so milli to milli cancel out. You get 220 divided by 4, that is 55 meters per second as the nerve conduction velocity. And so generally it is about this much, little around 48 or so or more. If it is 40 meters per second or 35 meters per second, we know that the conduction velocity is reduced, right? So there's cutoff points given in the reference values. We will not discuss about the values. We will discuss about the principle. So this is how you calculate the motor conduction velocity, that is distance between two stimulating points divided by proximal latency minus distal latency. Right? So the proximal distal latency is in blue, this one small value, proximal latency is in red, bigger value. So the bigger value minus the smaller value, take the answer, divide the distance by that answer, you get the motor conduction velocity. I think it is clear, right? Right, let's move. And one other thing that the recording person or the reporting person has to look at is the amplitude of the wave. That is also important in certain disease conditions. This amplitude of the compound action potential goes down. It becomes shorter instead of usual height. If it is small, that is also indicative of certain disorders, right? Right. So again, so you have latency. Stimulating point is here. That is the stimulating artifact, and this is the beginning of the rise of the wave. So to this point is the latency. So this is the latency value. This is the time axis, and then wave starts going up, and the maximum height that it reaches is what is called the amplitude of the action potential, right? From the baseline, how much does it go? And there are other studies, you can calculate the area under the curve, the surface area here. But for general purpose, I think what we want is latency, identifying latency and identifying the height, right? Okay. And this is the ENG machine. We have in our department somewhat very similar. I took it from the same company, Nihon Kodan machine, Japanese machine, which has some hardware here, and a keyboard is here, and underneath there's a computer. Everything is connected to a computer, usual desktop computer, with the special software. And from that software, you get on the screen, you see this distal latency, proximal latency of the median nerve, distal latency and proximal latency of the ulnar nerve. You can see original top two lines, action potentials are very similar in shape. The main difference is the latency period. Lower two are from a different nerve, maybe ulnar nerve. You see this latency periods are different, but wave height and form is very much similar. With a slight difference here, but that must be from the ulnar nerve. And then using this information, you calculate the motor conduction velocity to median nerve, motor conduction velocity of the ulnar nerve, and you have the values for distal latency of the median nerve and distal latency of the ulnar nerve. So also there, and using this information, you make your diagnosis. And in this one, I told you that there are things that we can rotate. So I think this right hand one, this one, when you rotate it, this dial, you give increasing current. So instead of 2 millivolts, if you want to go for 4 millivolts, you rotate one of these. And these other knobs are there to increase the scale sensitivity of the machine. So you can see, even if the wave is very small, you can increase the scale, so waveform will become more clear and bigger. And also you can change the x-axis gradation, like each square is how many milliseconds. You can change all those things. The fine technical details are not needed. But this is a junction box, just like in the EEG machine, junction box, where we connect recording electrode and stimulating electrodes onto these things. And I will show you them. And this is a stimulating electrode, the leftmost one. So this one goes and gets connected to the machine. And these are the, and this very small, about less than 1 or 2 centimeters or so. This one, and they connected to wire. The end of the wire is here, connecting to the machine, the junction box. And when you ask the machine to stimulate, machine will give an impulse and stimulate the nerve using these 2 electrodes. And then on the muscle, we connect this recording electrodes, and the other end of the recording electrode is connected to the machine, right? And recording electrode will not stay on the skin automatically. We have to have electrode paste, right? Nihon Codin, that's the company name. This is the paste for EEG, it says. So ENG also same thing, electroneurogram. Paste serves 2 things. One is you apply this paste on the surface here, and then you press it on the skin, and it will stick on. It is very sticky paste. So it will help to retain the electrode on the skin. At the same time, it will help to conduct electricity. So when the muscle generates electricity, that action potential information will be traveling through the electrode paste to the electrode. So this is the surface of the electrode, small cup-like, small depression is there, and you fill the paste with that and press it on the skin, and it will stay, right? And also, in addition to these 2, recording electrode and the stimulating electrode, you put grounding wire, some strap-like thing to earth the patient, ground the patient, so that disturbances will not be there. Right? Additional disturbances are not there. That is not shown. It's usually a Velcro thing. That's earth for the grounding wire, right? Okay. Now we will go to clinical situation, because one objectives asks us to talk about clinical situations where ENG is used. One of the commonest place that we use in our department is to diagnose carpal tunnel syndrome. So this is a diagram of the hand and the wrist bones. There's a what is called carpal tunnel, through which the median nerve travels, and across which there is what is called flexor retinaculum, fibrous band-like thing, which keeps everything in one place. And unfortunately, at this place, sometimes when people, it's actually common in people who use their wrists more. Say when you ride, motorcycle riders or musicians, pianists, the housewives who do a lot of cooking and sweeping and use the wrist always, they are more likely to develop it. And the median nerve here, shown in yellow in this diagram, gets compressed. Just a compression occurs, and when you flex the wrist, it will become worse. That is actually a test. You can do it. You can flex it and see whether the same pain can be induced. Because when the flexor retinaculum gets compressed against it, that's called Tinel sign, T-I-N-E-L, Tinel sign. Or you can hit the median nerve at the wrist, tap the median nerve like this, and pain will be induced or the numbness will be induced. Numbness is usually on this side. The thumb and the first other two fingers are involved. That is the median nerve distribution, and that is Phelan signs, Phan, Phelan sign. So those are clinical things which you will learn later. But compression here will induce pain. Those who have gone on a bicycle, as the second rider, not the person who takes the bike, but on the bar when you sit, after you go sometime, your nerves to the lower limb gets compressed over the bicycle bar, and you get numbness. And once you get off, it will be better. So it's the same thing. When you work too much, this nerve gets compressed against the edge of the flexor retinaculum, and you get pain. So what we do is we diagnose it using ENG, that is electrophysiological studies, and we will inform the surgeon that he is having compression. So the surgeon will do what is called carpal tunnel reduction surgery. He will section this, cut it, and just leave it open. And in 1 week, patient wound will be healed, and all the symptoms are gone, right? And if you do not do anything, due to the compression, the nerve will kind of degenerate, and the thenar eminence will also become atrophied. Atrophy of the thenar eminence will occur. This ulnar nerve goes outside. Ulnar nerve doesn't get compressed here. So therefore, that is why we record both distal latencies. When you stimulate from here at the wrist, generally in a normal person, it must generate compound action potential in less than 4.2 milliseconds. Yes, actually, it should be 4.1 or less. So if it is 4.2 or above, that is an evidence. It takes longer time to travel from here from the wrist stimulating point to induce the muscle. Because of the compression, signals will not go easily, and the distal latency will be prolonged. So prolonged distal latency is the hallmark of carpal tunnel syndrome. In carpal tunnel syndrome, distal latency is above the normal reference range, right? So more time is taken. Ulnar nerve, it doesn't happen. Sometimes, even if it is less than 4.2 milliseconds and the symptoms are very suggestive, we look at the ulnar nerve latency. Say if the ulnar nerve is stimulated here, and if it comes at say in 2 milliseconds, it will stimulate the muscle. But median nerve, when you stimulate, it takes 4 milliseconds. So this gap is 2 milliseconds. So one ulnar nerve is stimulated at 2 milliseconds, distal latency. Median nerve takes 4 milliseconds. It is less than 4.2. So that means it is not fulfilling the criteria for diagnosis of carpal tunnel, because carpal tunnel is more than 4.2 milliseconds distal latency. But here it is 4, but it is the wider gap from ulnar nerve. Actually, ulnar nerve and median nerve latency difference should be less than 1.2 milliseconds. So gap cannot be more than 1.2. Always, both of them are very close, but ulnar nerve is slightly faster or shorter distal latency, and gap is maintained within 1.2 milliseconds. So if the gap is more than 1.2, again it is suggestive of carpal tunnel syndrome. So distal latency of ulnar nerve and distal latency of median nerve should be within 1.2 milliseconds. The difference, right? Ulnar nerve, if it is say 2 milliseconds and the median nerve is 3.6 milliseconds, the gap is how much? 1.6. So that is an evidence of median nerve compression. If the median nerve distal latency is 4.5 or 6.5, for example, very large number, we don't have to look at ulnar nerve. If it is more than 4.2, it is diagnostic, right? So that is what. So latency difference between ulnar and median nerve is also one thing which is not written here. Or distal latency of more than 4.2 milliseconds with normal conduction velocity. Conduction velocity from the elbow to wrist should be normal. We calculate that also. I showed the calculation earlier. The distance divided by latency difference. So it has to be normal, because if it is slow, usually it is about 50 meters per second. If it is say 30 meters per second, it travels very slowly due to some other disease. When that bit is slow, this part is also slow. When this, because it's the same nerve, no? So therefore, it can become more than 4.2 milliseconds because of the some other reason, some other neurological damage, which is affecting the whole nerve. Conduction velocity is slowed down, and therefore distal latency is also prolonged. So in that case, we do not diagnose carpal tunnel syndrome, because if we tell surgeon, okay, his distal latency is more than 4.2 milliseconds, he has carpal tunnel, surgeon will operate, but still the nerve is sick, nerve is damaged due to some other demyelinating disease probably. So in that case, we should look at the nerve conduction velocity as calculated, I showed earlier, distance divided by latency difference, and then we tell, okay, his nerve conduction velocity is reduced. He seems to have some peripheral neuropathy, not carpal tunnel syndrome. Right? Evidence does not suggest carpal tunnel syndrome in that case. Right? Okay. So that is a little bit too complicated. You will learn it when you do neurology more details. But for now, understand, if there is a compression here due to carpal tunnel syndrome, distal latency will be prolonged. But at the same time, you have to pay attention to the motor conduction velocity, which has to be within normal range to diagnose carpal tunnel syndrome. So this is some picture showing atrophy of the thenae eminence. So is hypothenae eminence, which is looking normal. Here, atrophy. So therefore, if there is evidence of carpal tunnel syndrome, since the symptoms are suggestive, you have to advise. If you see a patient, you have to tell, you must meet a surgeon or go to the Department of Physiology and get this test done and undergo surgery early. Don't wait years. If you wait for years and years, this is the end result. And in this patient, even if you do carpal tunnel reduction surgery here, this will not become better. Nerve has already got demyelinated and compressed permanently and got ischemic probably and damaged. So therefore, no point in doing surgery when you come to this stage. So before this, you have to do. If this happens, patient's grip is weaker, he may drop glasses and things, and his hold is not firm. So those are the things that can happen. Okay. Okay, let's move down. Is it clear up to now? පැහැදිලිද? ඇහෙනවද? නිදිද? මොකද වෙලා තියෙන්නේ?
Yes, sir.
Okay. Is it clear up to now?
Yes, sir.
Have you
Yes,
been
sir.
taught about carpal tunnel syndrome in anatomy, clinical anatomy?
Of course, sir.
No?
Yes, sir.
Yes, the no, the you?
Yes.
Yes. No. Okay. Right. Okay, this is another clinical use. You can stimulate the nerve, say any place, doesn't matter whether it is proximal or distal, repetitively and record action potential. So in a normal person, you can give one stimulus, you get a compound action potential, you give another one, you get another compound action potential, you stimulate again, you get another compound action potential. They all look the same amplitude. But in patients with myasthenia gravis, when you give repetitive stimuli, the acetylcholine receptors are destroyed due to autoimmune condition, and action cannot get stimulated to the same height as with the repeated stimuli. So the first one, you will see a tall one, and next one is slightly shorter, next one is slightly even shorter. So you can see with the repetitive stimulation of nerve fiber, the height of the compound action potential gradually diminishes, right? So say 0.25, 0.5, 0.75, you stimulate. Same thing here, and your height has gone down. Decline in amplitude with repeated. That is why I said you have to look at the amplitude also making diagnosis with repeated stimulation, because fewer muscle fibers in motor unit are firing action potentials with repeated stimuli. That is why patients will feel fatigue, easy fatigability. By the afternoon, their eyes, they cannot even open their eyes, and they are weak, and that is myasthenia gravis. So electrophysiologically, you can get supporting evidence to diagnose myasthenia gravis other than the enterophonium test. You know the enterophonium test, no, giving short-acting acetylcholinesterase inhibitor to demonstrate improvement of symptoms, better symptom, outlook when you give that drug. That is a enterophonium test. Nowadays, I think they don't even do that now. Now they have what is called ice pack test. So they take the patient has ptosis because he cannot, because of muscle weakness, and you take a pack of ice and keep it over the eyeball, with the closed eye. You keep in, so take some ice to clear shopping bag probably, and keep it for a few minutes, and then take it out, and then ask the patient to open eye, and he will be better. Because when you keep it, the area will become cold, and the acetylcholinesterase enzyme activity will be reduced because of the coldness, and breakdown of acetylcholine will be slowed down, more acetylcholine will accumulate, and the same as giving enterophonium, and patient will be better. So that is a non-invasive, easy test, right? And patient can open eye without much problem, and he passes the ice pack test. Okay? So when you go to third year, fourth year, final year, people may ask, because enterophonium test has side effects, right? Because acetylcholine is accumulated all over the body, which can stimulate glands and secretions and bronchospasm secretions, bronchial secretions, and you have to get ready with atropine to block those effects. True that muscle power will be improved, but side effects cannot, right? So, so ice pack test is, or cold pack test is much easier one, right? Okay. And then few words about nerve damages. And actually, ENG can be used to study the patients with cut injuries. So if there's a sword or knife cut across here, the surgeon may suture it and wait for it to regrow, and after the wound is healed, we can do electrophysiological study and see whether the muscle gets stimulated adequately. That also has a place, but generally it's a clinical assessment rather than electrophysiological assessment most of the time. But we can do it without much problem, right? And this is some introduction to two types of nerve damage. There's a spelling mistake here. Should be demyelination. There's additional B. I will just leave it. Demyelination. Do it. Can you still see the presentation?
Yes, sir.
Yes, sir.
Right. So here, what happens here is, if you take a neuron, here one neuron with its axon, and there are, as I told you, hundreds and thousands of similar nerve fibers, axons going in one peripheral nerve, inside one peripheral nerve. And cell bodies are located in a motor nerve. They are located in the anterior horn cell, anterior horn, right? These anterior horn cells. In a sensory nerve, the cell body is located in the dorsal root ganglion. But whatever it is, sometimes they undergo pathological processes, and some of them are acquired conditions, some of them are congenital processes which may start later in life. Say acquired ones, say Guillain-Barré syndrome or some post-viral neuropathies. They may kill the nerves. They may say poliomyelitis, which will destroy the anterior horn cells, polio, right? Or there are certain demyelinating diseases, right? some autoimmune, some post-viral autoimmune conditions. So unfortunately, sometimes we don't understand the pathology. Whatever it is, they can broadly divide into neuronal loss or what is called axonal loss. So the whole nerve is dead. So assume, as I told you, if there are 1,000 nerves in the peripheral nerve, if 500 of them are dead, only 500 more is left. Now, if there are say 1,000 out of that, if 300 nerves are dead, only 700 is left. So that is axonal loss or neuronal loss. Is one type of disease. Sometimes the neuron is alive, cell body is alive, some axonal damage occurs, right? In the axon, demyelination occurs, right? So that is, these are called demyelinating diseases. So axonal loss is number of neurons are reduced. Here the number of neurons are not reduced. All the muscles get their nerve supply, but the impulse travels slowly. Right? So because of demyelination, because myelin will help to have saltatory conduction, here impulse will travel slowly. So the outcome, ENG outcome is different. When we using ENG, we can diagnose it. So this is the typical diagram. So this is normal stimulation. So this is distal stimulation. At the wrist, if you stimulate, you get distal latency and compound action potential. Top line. And second line, the bottom line, is the proximal stimulation, stimulation at the elbow. It takes longer latency because it has to travel from elbow to wrist, and then wrist to we don't have to break down and say the proximal latency is like this. So this is the normal pattern. If there is axonal loss, that means cell bodies are damaged, then number of neurons are not 1,000, maybe 500 now. What will happen? Less nerve fibers are stimulated, less muscle fibers are stimulated, and the compound action potential has smaller amplitude. It has got flattened, right? So it's a low, not tall, it's low. Demyelinating diseases are slow. Look at this one, latency is this much in the upper one, that is at the wrist. Here at the wrist, because of demyelination, when you stimulate at the wrist, it takes longer. When you stimulate at the elbow, it takes very long time, not like this. So it's a demyelinating disease because myelin is needed for rapid conduction. So the conduction has slowed down, and therefore, see, one is low, axonal damage is low, or neuronal damage is low, demyelination is slow. Okay? So that's the another place where we can use it. And in addition, there are other tests. Sometimes you stimulate here and you record here, and you record using a different mode in the ENG machine. So initial recording comes, but then wave, rather than coming here, it goes retrograde. The pattern goes to the spinal cord and comes back and stimulate the muscle again, and you get another wave, what is called F wave, right? So those studies are also there just to study any compressions in the elbow, the axilla, or the root lesions. Those can also be suspected or diagnosed using special ENG studies, but those are beyond our scope, right? So, but it's not limited to this. Neurologists do a lot of different things and study patients, right? Okay. So that is all I have to talk. So I hope you understood everything, and once you are physically available, you can come and see the machine in the department. There's and same thing I have shown, ENG machine. So that is what we do. We stimulate from two different places and do the calculation, right, of the conduction velocity. And also for carpal tunnel syndrome, we mainly use the distal latency. It has to be less than 4.2 to be normal. If it is more than 4.2 milliseconds, that is compression at the carpal tunnel and prolonged time to travel of impulse from the wrist to the muscle, right? Okay, so we will stop here. So how are you all doing? You all are in the Delta variant is there, be careful, right? Even if you have been vaccinated, you can get it. So be careful, which is dangerous. And WHO is also concerned. So stay safe. And total was about 115 ones, now 112. Right. Okay, I will get the recording done, but we will mark the attendance, right? So I will report to the head about who participated. I can get a log of who participated. Okay then. Any question? Right. Then so everybody stay safe and hope to see you when the situation is better and you will be coming for exams, no array of exams and the secondary reviews. Right. I'll stop here.
Thank you, sir.
Good night.
Thank you, sir.
Thank you, sir.
Thank you.
Thank you, sir.
Thank you. Right. Right. Okay. Bye.